Welcome everyone to this month's discussion of an interesting article published in the current issue of Neurogastroenterology and Motility Journal. My name is Purna Kashyap. I'm a gastroenterologist at Mayo Clinic in Rochester, Minnesota. It is my great pleasure to welcome Dr. Gerard Clarke. Dr. Clarke is a lecturer in the Department of Psychiatry and Neurobehavioural Science and a principal investigator in the APC Microbiome in Ireland at University College Cork. His research interests include the impact of the gut microbiome on brain and behavior across the lifespan, microbial regulation of tryptophan metabolism, and translational biomarkers of stress-related neuropsychiatric disorders. With over 130 publications and an H index of 64, he was included in the Clarke Analytics Web of Science Group 2019 and 2020 as one of the highly cited researchers list. His research has been recognized internationally by travel awards from European College of Neuropsychopharmacology, as well as the prestigious Career Development Award from the American Neurogastroenterology and Motility Society. He's also received an RSAT award from the Brain and Behavioral Research Foundation, and he's a partner in the Horizon 2020 DISCOvERIE Consortium, leading a project focused on the understanding of the role of gut microbiota in psychiatric comorbidity in irritable bowel syndrome. Welcome, Dr. Clarke, and thank you for joining us today.
Thanks very much. It's a pleasure to join you, Purna.
This is a very timely review. As you may know, last month we had a discussion with Dr. Grossman and Ms. Feingold about how to approach treating patients with functional GI disorders, often referred to as disorders of the gut-brain axis. So before we get started with discussing your recent review, I was wondering if you can provide a broad overview of the gut-brain axis, more so from a historical perspective, as this has been researched since the 1980s. And as I understand, gut microbiome is a more recent addition to the gut-brain axis. So it'd be helpful to understand how all of this came about.
Sure, and I mean it's a pretty broad question, really. I suppose in that most people would be familiar with the idea that the brain affects their gut and the gut affects the brain. You can think about butterflies in the tummy, when you're nervous, or maybe altered mood and anxiety when you have gastrointestinal symptoms. So even though they might name that as the gut-brain axis, they're well aware that this bidirectional communication happens, I suppose. And throughout, those doctors and patients have been also intrigued by this idea and trying to get at the basis for their intuition, I suppose. So from a historical perspective, you can really go back all the way to Hippocrates, where he talked about all diseases beginning in the gut, or Galen with his black bile associated with melancholia. And then more so in the 19th and 20th centuries, there was a bit of meat put on the bones of that discussion, I suppose. And from then on, you had somewhat of a debate, I suppose, over whether the gut or the brain had primacy in this, and different theories kind of running in parallel to support both versions of the direction of the causality, if you want. So there's some really important milestones along the way. You may be familiar with the surgeon William Beaumont and his patient Alexis St. Martin, who when he was accidentally shot but survived, it opened up a gastric stoma, which Beaumont then investigated. So he really had a window into the gut-brain axis of his patient, and could see, that the emotional state of the patient was affecting his digestion, and that gastrointestinal discomfort then was also manifested in altered mood and emotion. And I suppose moving on from that, then you had William James and Carl Lang, who thought that emotions were coming from the gut, versus the ideas put forward in the 1920s by Walter Cannon, I suppose, where he really favored the primacy of the brain, but at least he recognized that the brain had an important role in controlling aspects of gastrointestinal function, and really put forward the importance of considering the emotional state of his patients in efforts to improve their gut function. And even the psychoanalysts got in on it then. You could see Sigmund Freud, when he was talking about some of his patients, linked their early life adverse experiences to gastrointestinal dysfunction as well as psychological dysfunction. And then observations throughout history, I suppose, that got people thinking about this bidirectional communication network. We had the idea is that stress exposures were impacting on gut function. Evidence from soldiers fighting in Dunkirk that they had increased gastrointestinal symptoms and ulcers. Similar problems reported maybe in London during the air raids in the Second World War. And then maybe some setbacks as well to the idea, in that even though it was a big breakthrough to realize that gastric ulcers were bacteriological in origin, it kind of pushed the psychological component a little bit on the back foot again, because it kind of led people to dismiss maybe the psychological components and indicate or think that they were peripheral to the disease processes. But I suppose what really, the developments that got us to where we are now with our understanding of the gut-brain axis were heavily influenced by the neuroimaging studies from the 1980s onwards, which were really able to show the bidirectional nature of this network, and the fact that studies with experimental interventions extending the gut could lead to activation of important pathways in the brain, and that those kind of pathways were then hyperactivated or exaggerated in gastrointestinal disorders like irritable bowel syndrome. So really, the concept of a gut-brain or brain-gut axis has been around for a long time, and it's within that kind of framework then that the microbiota has emerged as maybe an important player in the picture.
That's great. Thanks for giving more of the big picture view, and I agree that's a really broad area. And I was just trying to get a feel for where we were and where we are headed as we talk about this. So building on this, could you talk a little bit more about signaling pathways which are involved in this gut-brain axis, and what are the diseases you would traditionally think that are affected by them? There's always this feeling that when we bring the brain into the picture, that it's predominantly psychiatric illnesses. So if you could tell us a little bit more about the pathways and the diseases that you feel and how they fit into this mold.
Sure. Well, the classical framework, I suppose, for the gut-brain axis revolves around the central nervous system, and then these different pillars that are critical features of the network. So you have the autonomic nervous system with its various arms. You have the neuroimmune and neuroendocrine systems. So the hypothalamic pituitary adrenal axis, for example, is very important. The immune system is a big component, and the innervation of the gastrointestinal tract by the vagus nerve offering this very important highway of communication between the gut and the brain. And classically, that's been thought about in the context of a broad range of digestive disorders, host metabolism, food intake, chronic pain disorders in the gastrointestinal tract, as well as you said, these psychiatric disorders. Because if you think about it from a neurobiological perspective, at least many of these pillars of the gut-brain axis are also dysfunctional in disorders like depression, for example, where you have this low-grade immune activation and increased activation of the HP axis, so high cortisol levels, which many of these features are also commonly found in subjects with IBS.
Yeah, I think that makes sense. Yeah. So where do you think we stand with our current understanding of how microbiome fits into the regulation of this axis? What you described are very classic pathways, which we've read about, but how do you see how the microbiome fitting into regulation of this? And also, what is the basis for bringing the microbiome into this axis per se? Because while we've seen a lot of studies which show differences in the composition of bacteria in both gastrointestinal and psychiatric conditions or GI conditions with psychiatric comorbidities, what would be the relevance of these changes, and are they enough to make that link at this point?
Yeah, so I suppose there's been a number of experimental strategies or lines of evidence that have helped stitch the microbiota into the gut-brain axis. From a preclinical perspective, getting rid of the microbiota, so that the studies of germ-free animals have really highlighted the extent and the scope of influence of the microbiota on brain function and behavior via this axis. So we know critical aspects of brain structure, brain regions which are important in psychiatry, like the hippocampus for learning and memory, the amygdala for fear and anxiety, the prefrontal cortex for the integration of emotional experiences. All of these markedly different as a consequence of growing up germ-free, in addition to the behavioural profile of these animals, which is markedly abnormal in terms of anxiety, for example. And other supporting evidence then came from animal studies given specific strains of bacteria, probiotic candidates, for example, that subsequently showed alterations in behaviour and some of these signalling pathways. There's a line of evidence, I suppose, coming from population-based studies looking at people exposed to infection. So you may be familiar with the Walkerton outbreak in Canada, and subsequent to that, the people who were infected with the E. coli in that contaminated water went on to show alterations in things like depression and behavior and gut-brain axis symptoms. And then, of course, we have the evidence from preclinical studies with antibiotic administration showing that at various stages of life that can have an impact on fundamental aspects of brain function as well. And I suppose we can synergize that data with much of the information that come from earlier observations in relation to the use of antibiotics to control hepatic encephalopathy. Now, in terms of the alterations that we've seen in gastrointestinal and psychiatric conditions, I suppose a lot of those initially were compositional in nature. And a number of disorders now, it has been shown that there's a different either composition or function of the microbiota compared to healthy controls in disorders like depression or irritable bowel syndrome. Now they're kind of snapshots in time. So of course, there's been attempts to see whether those particular configurations that are associated with particular disorders might have relevance for symptom expression. And that's where really the FMT studies come into play, the fecal microbiota transplantation, where it's been shown that you can transfer behavioral phenotypes via the microbiota, which is taken currently as one line of evidence supporting a causal role for these microbiota alterations in the expression of different symptom profiles. So I think the studies we've seen today are certainly sufficient to make a link. And it'll be interesting to see moving forward if we can get a bit more into the mechanisms at play.
Thanks, and I didn't mean to disorient you when I threw up this image from your review on the screen up here. I know people who are listening to the podcast will not be able to see the screen, but it'll be available in the video format. And it was just as a prelude to my question coming up, you obviously try to convince us that it's not just compositional difference in the microbiome, but in fact, a causal link based on transplanting microbes from patients with these conditions into animal models. So obviously the next logical question would be, what are the bacteria doing in order to influence signaling pathways? And, or in other words, what are they producing, or how are they influencing some of these signaling pathways? Is it by producing molecules of their own, or by exploiting the host pathways, or a combination thereof?
Yeah, I mean, that's an interesting point. And I think we're probably missing some of the fine granular details of how these pathways are modulated. But within the framework of the gut-brain axis, we know, for example, that the key pillars are influenced by the gut microbiota. So we know that the bacteria play a role in priming the hypothalamic pituitary adrenal axis, the stress response system. We know they're important for educating the immune system, and there's a constant ongoing dialogue between these pillars and the microbes. And of course, some of the best mechanistic evidence to date in this field comes from the use of vagotomy to demonstrate that is an important pathway between or mediating the effects of the microbiota on brain function along the gut-brain axis. Now, in terms of more definitive mechanisms, we know, for example, that these microbes are like mini factories. You know, they're churning out a lot of microbial metabolites. When we feed ourselves, we're not just feeding ourselves, we're feeding the microbes as well. And they can produce things like short chain fatty acids, which are capable of interacting with host physiology to modulate host metabolic pathways, such as those linked to tryptophan metabolism and serotonin production, for example. We also know that the microbiota can produce some of the same neurotransmitters that our nervous system uses. So GABA being one example. So there's a possibility that they're producing GABA, which is maybe interacting with receptors expressed on the vagus nerve to produce some of the benefits that we've seen. And the same goes for, I've talked about their capacity to modulate host metabolic pathways like tryptophan, but they can also use tryptophan themselves. And it's becoming much clearer now that the metabolites produced by the bacteria themselves from tryptophan may also, these indoles may also have an impact on host physiology as a potential mechanism and way in which they can impact on relevant signaling pathways in the gut-brain axis.
Thanks. You know, while we're talking about this, I just had a thought, and I thought I'd clarify this, because oftentimes people get confused between things that the bacteria are producing in the gut and whether they directly go into the brain and have an influence on the brain, or they're actually working on the peripheral nervous system or on the vagus and then sends other signaling molecules into the brain. You know, often this comes with conceptions around serotonin. If the bacteria lead to increased serotonin production in the gut, that doesn't necessarily translate to increased serotonin in the brain. So are there molecules which freely cross the blood-brain barrier versus others which have a different signal transduction mechanism from that?
Yes, I mean, some of the classical neurotransmitters that the bacteria will produce, like serotonin and GABA, are not thought to cross the blood-brain barrier in appreciable quantities. So their scope for directly impacting the central nervous system in that way is maybe a little bit limited outside of some areas of the hypothalamus, for example, that might lack protection from the blood-brain barrier. But the precursors can. So tryptophan readily crosses the blood-brain barrier. There's a transport mechanism which it can be taken up into the brain from. And some of these other neuroactives produced from tryptophan as well, like the kynurenine pathway metabolites that you might have heard of. So yeah, I mean, there's multiple options there, I suppose, but certainly the tryptophan we consume in our diet needs to be made available. It's an essential amino acid, so we have to have it available for conversion into serotonin in the central nervous system. So probably the microbial control of precursors may be important in the context of central nervous system neurotransmitter alterations.
Great. So that brings me to another interesting question, because like you mentioned, a lot of these studies have been done in animal models. So I guess my question is, how well can we model some of these diseases of the gut-brain axis in animal or other models, in vitro models? And you know, both historically and moving forward, how well do you think the findings from these models translate to humans?
Yeah, I mean, that's an interesting dilemma in a way, I suppose. And this has been approached from a number of different perspectives, I suppose. So I think maybe historically and initially, there was a lot of focus on models that captured specific symptoms. So models of visceral hypersensitivity and abdominal pain, or screening tests for alterations in motility, for example. But we were fortunate to have Eamon Quigley here for a long time while I've been in Cork before he left to join you in the States, and he always heavily emphasized the point that, you know, IBS isn't a disorder that just relates to abdominal pain or altered motility. It's much more complex than that, and there's always a challenge preclinically in trying to get all the features of a complex heterogeneous disorder into one model. Now, in the review, we argue that there are some good options in this regard. And the fecal microbiota transplantation studies, particularly the ones that are covered in some of the articles in this issue, would support that, and that you can transfer multiple aspects of the phenotype that's associated with IBS, both gastrointestinal and psychological features. So the transfer of both altered motility, for example, and increased anxiety, as we'll talk about later in the context of the work from Elena Verdew and colleagues. The other model that we think is very good at trying to capture the multiple features of IBS is this early life stress model we call maternal separation. And what we've seen there, and work from my colleague here, Siobhan Mahoney, what she would have shown is that this early life stressor, when applied in adulthood, the animals have multiple features of relevance to IBS. So they have visceral hypersensitivity, but they also have the depressive-like behaviors and the alterations in the HbA axis. So from that sense, from that perspective, the diseases can be modeled reasonably well. And then we need to learn a little bit more from that. And that's why I think the FMT studies are primed really not just as a vehicle to show causality, but also as a means to really get into the nitty-gritty and dissect the mechanisms that are at play. In terms of how well these models translate to humans, I suppose you can evaluate them as they would have been done traditionally in the context of how valid they are across face, construct, and predictive validity. And certainly the methods that we would use to assess or screen probiotics to look for things like depressive-like behavior or alterations in anxiety-like behavior have very good predictive validity, and they would have been used a lot in the pharmaceutical industry as screens for more classical antidepressants. But there's always going to be some, no model is perfect, and there's always going to be some maybe attrition along the way. And I can give you some specific examples, maybe from our own research, where our approach really is to screen in our preclinical models for candidate, what we call psychobiotics, so turbocharged probiotics that might be able to impact mental health. So when we screened for those and identified some candidates and moved them into our healthy human subjects, we had one very positive example, one promising study where a lot of the findings from the animal studies did translate pretty well, and that was subsequently replicated in a different laboratory using slightly different approaches. But then we went back and reassessed one of the probiotic strains that had one of the strongest preclinical profiles, and when we moved it into our healthy human subjects, it did absolutely nothing. So, I think getting a better handle on the mechanisms that might explain why one worked and why one didn't will be important, but it does show that at least there is some confidence that things will translate, as well as the recognition that the models aren't perfect and there may be some failures as well.
I think that's understandable when we think about some of these models, because obviously a lot of people rely on animal research, and we know that not everything that we do would translate, but each model may be able to provide some bit of information which could be used, and it may not be a one-to-one translation that people are expecting here. But clearly the goal of some of these models is to develop or move the field towards therapeutics, because in essence, they're not just models to understand mechanism, but also models where you can intervene and develop preclinical insight into therapies. So what would you say is the current state of therapies where specifically targeting the microbiome in disorders of the gut-brain axis?
Yeah, so I think we probably know most about this approach and the different options in the context of irritable bowel syndrome. Maybe it's been well evaluated recently by the AGA and other systematic reviews and meta-analysis. So the most used option, I suppose, would be different strains or combination of strains of probiotics. And although some studies have been positive in this regard, there are also some studies where the effects have not worked out too well. And I suppose that really harks back to the important distinction to note that the effects of probiotics are very strain specific. So we can't assume that as an umbrella group that they're going to have beneficial effects, which can make it difficult to synergize the data, I suppose, in these systematic reviews and meta-analysis. But from the recent AGA review and recommendation on this, they didn't really find that there was sufficient evidence to make a strong recommendation for a particular probiotic or combinations at this stage. And I think the same is probably true in prebiotics, even though there are some promising studies. It's less well investigated at the minute than probiotic studies. There are some good options in terms of looking at inulin or looking at FOS and GOS, for example, and some individual studies that have shown a lot of promise in that regard. But again, probably insufficient data at this stage to recommend going straight to the clinic with them. I think there are some interesting counterintuitive options that are being looked at in a way. We think about the rifaximin, which is an antibiotic, which you would not maybe conceptually think would be the best option to consider for IBS, but it has shown some benefits and is, I think at the minute, has some recommendation level for diarrhea predominant IBS. And then we can think as well about diet, and there are some dietary restriction programs like the elimination of FODMAPs from the diet that have shown some benefits in terms of symptomatic control. But maybe what's interesting about those is that even though they're producing symptomatic benefits, they're having effects on the microbiota, which we would perceive to be detrimental, like the depletion of bifidobacteria strains. So I mean, that's an interesting side thought there. And then, of course, there's the FMT studies and a lot of evaluation of the potential of SMT and some FMT in small studies, some open labeled, and then more recently some larger randomized controlled trials as well, some of which have come up with positive results and some of which have not been so encouraging. So again, the jury remains out on that, but I think there's a move to recognize that really the success of the FMT probably depends on a lot of different factors, including both the donor and the recipient microbiota configuration at baseline. And then some of the other options that are used more routinely in IBS may also have an impact on the microbiota. So we're seeing more and more this drugs and bugs interaction, and that some of the antidepressants, for example, might have antimicrobial potential and change maybe the composition of the microbiota. So there's a lot of interesting angles there, and a lot of options certainly coming through in the preclinical studies for further evaluation in the clinical situation from a research perspective, at least.
Great, and I think as you talk about this, I think this is a good segue into the paper that you're talking about from Dr. Elena Verdu's group, which is also published in the current version, issue of the Neurogastroenterology and Motility Journal, which is titled Saccharomyces boulardii CNCM I745 modulates the microbiota gut-brain axis in a humanized mouse model of irritable bowel syndrome. And so this was one of the motivations for us inviting the mini review, so that we can put it in the context of so we can put this study in the context of the mini review. And you've already touched on some of these issues in terms of the humanized mouse model and how we can evaluate the role of specific bacteria on the gut-brain axis. So I just wanted to get your thoughts of how this study fits into our current understanding of the gut-brain axis, and what are the things that we can take away from the study, and what are the things that still remain to be seen.
Sure, yeah. So I mean, the study really builds on some foundational work from earlier research from the group, where they show this really neat finding in that they took IBS patients and they divided them into those with IBS only and then IBS and comorbid anxiety. And really neatly what they were able to demonstrate was that when you transferred the microbiota from those stratified patients, that the animals who received them in the case of IBS only displayed gastrointestinal symptoms, and in the case of IBS and anxiety displayed a combination of altered motility and increased anxiety-like behavior. And that's really the basis for the current study, so that the concept that you can transfer specific combinations of gastrointestinal and psychological phenotypes via the microbiota. So in the current study, they went back to this approach, and this time took the donor microbiota from an IBS patient who had comorbid anxiety. Again, they showed again that the phenotype that emerged in the animal was one of altered motility and increased anxiety. But this time, in a really innovative approach, what they were able to show was that treating that microbiota, or that animal that had been in receipt of that donor microbiota with the Saccharomyces boulardii, was able to reduce the anxiety-like behavior, but didn't have as much of an impact on the gastrointestinal motility alterations. And then they also went a little bit further and tried to get at some of the mechanisms that are at play there, and they identified here an important role for the impact of this Saccharomyces boulardii on indole production in the gastrointestinal tract. So they used both in vitro approaches to look at this, and they also showed elevated levels of indole in the feces from the mice treated with the Saccharomyces boulardii. So it's a really nice innovative expansion of their original observations, and gives some good indications that a microbiota configuration reflective of IBS with comorbid anxiety can be targeted with this specific probiotic to improve aspects of behavior.
Thanks so much. I think as we get towards the end of our discussion, I thought I'll ask you, what are the major gaps in our understanding of this axis, and what do we need to fill these gaps, or in other ways, how do we accelerate the translation of our understanding of the microbiota gut-brain axis, as we now refer to it, to developing new treatments for our patients?
Yeah, so I mean, it's an interesting question to see where do we go from here. So we've got very good, I suppose, at looking at the composition of the microbiota, but we really now need to accelerate our attempts to understand the functional implications of any compositional alterations which are present. And really as well, I think we need to go more for longitudinal studies in very well phenotyped patients, so that we know the symptoms of IBS wax and wane over time. So if we can track the microbiota along with the symptom profile alterations in a longitudinal nature, I think it'll get us a long way towards understanding better what's going on here. This is something that we're kind of very interested in doing at the minute, particularly in the context of psychiatric comorbidities in IBS. So we have a study funded by Horizon 2020 at the minute in Europe, with a lot of partners across various sites, called DISCOvERIE, where we're trying to get at the longitudinal fluctuation and comorbid microbial signatures in IBS. And in Cork here, we're the preclinical site for that, where we're going to use these FMT approaches to try and really get a better handle on the mechanisms involved. I think if we can get a better handle on the mechanisms, that's a good route towards expediting this into the clinic, because that, in tandem with the realization that the baseline composition and function of the recipient microbiota might be important, and how somebody responds to a microbiota directed intervention might lead us down to the area where we have kind of biomarker panels and companion biomarkers and diagnostics, where we know that particular interventions are more likely to work in specific subgroups because they have signatures that are predictive of response, and that would be something that would be really valuable for the field, I think. But there's a lot of work to do. It's really exciting area to be in at the minute. I think one of the other gaps that we have maybe is our poor enough knowledge of the biogeography of the gut microbiota in the context of the brain-gut axis and disorders therein. So at the minute, we rely a lot on fecal microbiota analysis, which has proven very useful for sure. But there's a lot of variation, both longitudinally along the gastrointestinal tract and also from lumen to mucosa. And new technological innovations have brought us to the point we're at now in terms of our ability to scope out the composition of the microbiota. So I think we look forward with anticipation to some new technologies that will be able to give us some real-time information about microbiota composition and function, and feedback from those, maybe smart capsules, for example. So there's a lot of interest in areas, and I mentioned bugs and drugs earlier on as well. That's a really important area at the minute, understanding these interactions and how they might influence how the host responds to therapeutic interventions as well.
All right, that sounds like it's going to keep you busy for a long time.
For sure.
But thanks again for providing such a comprehensive overview. And before we sign off, do you have any parting thoughts or anything that I missed or you wanted to tell us about before we close the session?
No, I think we've covered it pretty well. I mean, I was really delighted to have the opportunity to contribute a mini review to this issue, and it was really nice to sit down and think about the implications of the study from Elena and colleagues, which is a really, as I said, a really innovative approach to try and counteract the detrimental effects of particular microbiota configurations.
Great, thank you. With that, I'd like to thank Dr. Gerard Clarke for the excellent discussion on his mini review on gut microbiota brain axis, and also discussing the paper which was published in the current issue on Saccharomyces boulardii and how it modulates the microbiota gut-brain axis in a humanized mouse model of irritable bowel syndrome. And I would also like to thank our listeners for tuning in, and I look forward to welcoming you again next month for another exciting discussion on a manuscript.